Wow.
So she's there.
Yeah.
And the other one is Hyperkalemia. She has joined Roche. She's at Canada.
Okay. Also, you keep on making trips.
So अभी December में they all गए.
हाँ.
They were here for 10 months because
Okay.
2 साल में मुलाकात नहीं हुई थी.
Okay, okay, very good.
So अभी we will be going now.
Yeah. Good. Enjoy. Okay. Ciao. Yeah, sure. Same. Bye.
Around what is he?
He was a neurologist.
Urologist.
A surgeon.
Urologist.
अर्जुन में केस प्रिफर करें क्या प्रैक्टिस करें हाँ क्या करें
नहीं ये तो बाबे ये तो बहुत मोटो मानस
हाँ तो क्या करें
ये बड़े अलग जगह पे हैं तेरे क्या चीज मुझे खबर
सारू है छोकरियों तो छे नहीं कनाडा अमित इधर थोड़ा कचरा पड़ा है
देख मैंने एक वो फोटोग्राफ तेरे को व्हाट्सएप पे भेजा है हा?
अमित
अमित Ajin, who's answering today?
Dr. Nikhil Amirchetty from Chennai and Dr. Yasir Lone from Koklaban.
Dr. Yasir and Dr.
Nikhil, sir, from Chennai.
Okay.
Dr. Ji, please make Nikhil Amirchetty host, co-host. Pankaj Maheshwari, sir, co-host. Dr. Ji, make Dr. Yasir Lone co-host.
तो बस आवे एंड में काम लग कारण कि डॉक्टर medicina पैसा वापरायचा
Okay.
હવે આપણે પાછું લાગીને ત્યાં સુધી
Okay. Hello. Achin, we just wait for 2-3 minutes, 4 minutes, and then we start.
Okay, sir.
Dr. Hiren is joined.
Not yet, sir. Venkat Gite sir has joined.
Yeah, Gite sir has joined and Maheshwari has joined.
Yes.
So Prashant has joined.
Prashant sir hasn't joined, sir.
Okay, no problem. Yeah, Dr. Gite, Dr. Pankaj, today, can you hear me?
Yes, I can.
Yeah. So today, now we have got one case. Basically, we will discuss little in length. That is a solitary kidney.
Right.
And then we have got anomalies. So in between, Achint will just classify all the anomalies, and there are different cases. But in this, it may not be as per the like exam,
Right.
what we have done. So you will have to tell the students what they are supposed to answer in the exam also. So chronologically, we'll say what has been done in these patients, and you people, can ask them and advise them how to answer in the exam.
Sure.
Sure, sir.
Yeah.
Should I start, sir?
Yeah, I think we should start now.
Okay, sir.
Yeah.
A gentleman, 52 years of age, Hindu, resident of Mumbai, shopkeeper by profession, came with complaints of mild left flank pain since 2 days, complaints of not passed urine since 1 day.
Yeah. So who two are answering? Yasir and
Nikhil.
Nikhil. Yeah. So Nikhil, what are the questions you like to ask?
Sir, sorry, sir. Can you just repeat this? 27.
Gentleman, 52 years of age, Hindu, resident of Mumbai, shopkeeper, came with complaints of mild left flank pain since 2 days and not passed urine since 1 day.
Oh. Yes, sir. Sir, I would like to know the characteristic of the pain, sir. And he has not passed urine. Absolutely, there is no amount of urine passage. And the intensity of the pain, sir, like how severe is the pain, and the localization of the pain, where is the pain exactly located to? This thing I would like to know, sir.
Yeah. So ask Yasir, what are the questions? You just elaborate and then we'll go ahead.
So first, we like to elaborate the pain.
Yeah. To tell us.
The check on it is mild the three things which are mentioned is the severity that's mild, the location that's left, and duration is 2 days. Rest, I will like to ask whether what was the nature of this pain, whether this was poly, non-poly, the progression of the pain, whether it was how was it intermittent or did it increase or decreased in intensity, and did any medication help in the pain intensity? And after that, I would like to ask any this radiation or not, any aggravating or relieving factor. And regarding the second complaint that's not passed urine since 1 day, I would like to ask whether the patient has any swelling, in the abdomen, or he has pain in the lower abdomen. And would like to ask if patient has decreased in the urine, has he any past history of any decrease in the urine output? That's all. And in the negative history, I would like to ask, is there any history of fever? Is there any history of dysuria, any history of lower urinary tract symptoms? Any history of this facial puffiness, breathlessness? Any history of lower limb edema, that's pedal edema? Any history of vomiting, nausea?
Yeah. So Dr. Venkat, you want
So yes,
to?
here,
Yes, sir.
yeah. After listening this complaint, and only two important points. One is left line pain, another is retention. So whenever
Yes.
there is a retention, the cause, one should think about cause for retention. So what are the possibilities? The first possibility, it may be
Yes, sir.
bilateral
First, regarding
ureteric obstruction. It may be unilateral
yes,
ureteric obstruction. It may be bladder stone causing the implication of bladder leak. It may be urethral
yes,
stone. It may be anything. It may be
yes, sir.
solitary functioning
Regarding
kidney with stricture. We don't know it is
yes,
stricture in the urethra.
regarding not
Bila-
passing the yes,
if you want to combine these two findings with each other, we have to think about bilateral obstruction, unilateral obstruction, supravesical, infravesical, and vesical. And according to that, we have to ask for the
yes, sir.
negative.
Sir is absolutely right, and I think that you should have elaborated more on low unit tract symptoms. That would have told you whether this is something acute that has happened or this has been going on since 1 month. These two complaints, whether they are suddenly they have come or whether the low unit tract symptoms were there and now he had pain and he's gone into retention. So why sir is talking about solitary kidney, bilateral ureteric obstruction, blah, 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 because patient is 52 years old. But if you elaborate the low unit tract symptoms, then you will know what is going on.
Yes, sir. Also, sir, regarding not past the urine since 1 day, I would like to ask is there any, are there similar complaints in the past? Has the patient any history of surgery? Has the patient any history of catheterization for that?
Okay, fine. Maheshwari ji, you want to add anything?
No, nothing to add, sir.
Okay, fine. Achin, go ahead.
Patient was apparently asymptomatic 2 days back when he started developing left flank pain, insidious in onset, gradually progressive, dull aching type, intermittent in nature, not relieved by medication, no specific aggravating factors, non-radiating type, no positional variation, associated with not passed urine since 1 day, associated with exertional dyspnea, not associated with lower abdominal pain or swelling. No history of nausea, vomiting, no history of fever or burning maturation, no history of lithoria, hematuria, no history of trauma, no history of any LUTs.
Okay. Past history?
Past history, patient is a known case of hypertension since 10 years on medication, and there is no history of any diabetes mellitus, ischemic heart disease, COX or COX contacts. History of right laparoscopic nephrectomy done 8 years back, but patient doesn't know the details. and he just said verbally the kidney wasn't working, but there are no papers available.
Okay. So Yasir, you want to know anything more?
He has already mentioned there are no details regarding the previous this surgery. Rest things are mentioned, sir.
Sir, about the past surgery, that is significant history we have, sir. Like 8 years back, this patient has undergone an nephrectomy on the right side. Though he doesn't have paper, still I would like to elicit some history, sir. Like whether how many days was he operated, was he admitted in the hospital, and was he shown any specimen after the surgery, like stone was given to him, or what are the details about that? I would like to know, sir. And what kind of surgery was it? Like laparoscopy? Was it mentioned, sir? Like laparoscopic nephrectomy was done. Like those things I would like to know.
Yes, definitely one should ask the details about the prior surgery in terms of the diseases where it can reflect in future in opposite kidney.
Yes.
Okay. So histopathology is important.
Yes.
The cause of nephrectomy is very important.
Yeah.
So some diseases are familial, some diseases have multiple time recurrences. Is it malignancy, non-malignant, stone, non-stone? Why it is removed in emergency, in plan surgery, then laparoscopy, open surgery. Already they told laparoscopy. And after 8 hours, he had a now pain on opposite side.
Yes.
And if after completion of the history, if lower tract is rolled out,
Yes.
then technically he has a only functioning kidney on opposite side, that is left side,
Yep.
and that is paining. So here again the differential is narrowed down to one side only in terms of the supravesical obstruction. So it may be anything now. Supravesical, it may be stricture ureter, it may be stone in the ureter, it may be stone in the pelvis, it may be anything. So according to that, we have to go ahead. Then if it is solitary functioning kidney, then obstruction in the solitary functioning kidney is very important.
Yes.
Yeah. See, the histopath report is very important. For example, patient says that he has got he had a pyelonephritis secondary to stone. Then you can say that, preferably the chances of right side also calculus obstructions are very high. Same way, if he says that it was the report is saying that it is tuberculosis, then you know that it must be right-sided stricture secondary to GU-COX. So, of course, histopath report is very important, and if you get it, it will narrow down your diagnosis. Okay, fine. So, Yasir, Nikhil, now next what?
Sir, with a solitary functioning kidney, now my immediate thing would be like this is an emergency because only single and no urine is coming. So I would like to do an office ultrasound first to diagnose.
So what is, first of all, now what is your differential diagnosis?
The differential diagnosis is suspecting it to be a stone disease on the left side.
Why you are saying stone disease?
Sir, because he's having pain concentrated onto the left flank region, sir, and there is anuria, so I'm suspecting it to be a stone causing obstruction. Would be my first differential diagnosis for this patient. And then it could be, because the reports are not available, it could be this thing also, sir, malignancy also, 52-year-old.
Chances of getting left obstructed kidney is very high. So the cause of obstruction may be anything.
Yes.
Okay. The cause of obstruction may be, yes, previous kidney, if it is removed by tuberculosis, for tuberculosis, now this side kidney may have tuberculosis. Previous kidney, if it is removed by stone disease, this time may not be removed by stone disease also. There are chances of stone disease in opposite kidney. So these are the more commonly, if suppose this is a bilateral patient with bilateral kidney in situ. What is your differential diagnosis? It is stone disease, PUJ, cystic disease, any obstructive malignant or non-malignant obstruction. This is the commonly encountered pathologies for going for the cause of obstruction. So same sequence will be there. It may be unilateral, it may be bilateral. The cause pathology will not change.
So, how will you explain? You should say, okay, sir, probably this is a solitary obstructed kidney giving rise to anuria. That is your one of the diagnosis, because the patient is not giving any history of distension or mass in the lower abdomen, and there is no pain in the suprapubic region. So probably this is the first diagnosis, but you will like to rule out even the obstruction. Okay, outlet obstruction. Fine. So now next what do you want to do?
Sir, I would like to.
Examination.
Yeah. Okay, Nikhil, you say. Then we'll ask the. I'll tell the name also. Okay, Nikhil, you answer.
Sir, I would like to do a quick examination for this patient, sir, like abdominal examination, whether there is any fullness present for this patient, the tenderness is present, any mass is palpable or not. This I would like to see in the abdominal examination, sir. And also suprapubically, I would like to palpate if the bladder is palpable or not, is it tender or not. And then coming lower down, sir, I would like to see whether there is any phimosis or VFC changes or any structure-like things are present or not. And DRE, I would like to see the complete also.
Nikhil, please go systematically. In general examination, what are the important things you will like to see?
Sir, in general examination, I would like to see for the pallor whether it is present or not, sir. And the edema, I would like to see, sir, whether there is any lipidinopathy present or not. So I would like to see, sir, in general examination. And fullness, like general edematous, like fullness of the abdomen and umbilicus position, I would like to see, sir, in general. And lower limb edema also I would like to see.
Yasir, in a general examination, what are the important things you want to see?
First, whether the patient is sitting comfortably in the bed, well oriented to time, place, and person. And then I would like to note the vitals of the patient. I would like to note the pulse, BP of the patient. And after that, is there any pallor, icterus, cyanosis? And after that, sir, I would like to do the abdominal examination. In the abdominal examination, I will do inspection, palpation, percussion, and the auscultation. The inspection, I would like to see whether there is any, because the patient has history of right-sided nephrectomy. Still, I will try to search for any scar. There is any visible scar or not. Rest any visible other are the all the quadrants are moving with respiration or not? Is there any visible peristalsis? Is there any visible veins? After that, on the palpation, I would like to confirm my findings on seen on the inspection. And if I have some positive find, I would like to palpate that. And in the palpation, I will like to see if there is any organomegaly or not. And then moving to the percussion, I will do the percussion. If there is some positive finding, I will try to know that after that auscultation, I would like to auscultate. And after that, I will like to do other systemic examination like the respiratory system, cardiovascular system. That's all.
So just tell me only the important things which you are going to get. You are interested. So everything you have told me, just tell me in short, what are the important things you will be.
I would like palpation of the supra. Is there any fullness in the suprapubic region? Is there any tenderness or palpable swelling in the renal angle? And genital examination. That's also. Then DRE as a part of the examination.
Okay. Let us see what we are getting. Achin, go ahead.
Yes, sir. Patient is conscious, cooperative, well oriented to time, place, and person, moderately built and nourished. Pulse is 110 beats per minute. BP is 170 by 100, measured in sitting position. Respiratory rate is 26 cycles per minute. Patient is afebrile, SpO2 is 98% on room air. BMI is 26 kg per meter square. Karnofsky score is 100. Bilateral lower limb pitting edema present up to the calf with mild facial puffiness. and there is no evidence of pallor, ectasis, cyanosis, clubbing, or lymphadenopathy. And head to toe spine examination overall looks normal.
Yeah. So now you understood, Yasir and Nikhil, what
Yes,
are the most, when you are suspecting that patient has got anuria, that also since last more than 24 hours, okay? Immediately if a patient comes, you may not get the changes, but when it is, see the creatinine rises very fast if it is anuria. Fine.
Yes.
So in that case, what are the vitals are very important. So in exam also, these are the things you must be expecting something. So you have to talk about it. Okay. Fine.
Yes.
Okay. Achin, go ahead.
Yes.
Acha, Dr. Gite, Hiren, you want to say anything? You want to elaborate on this?
No, sir. Only while going further, as they were suspecting unilateral obstruction, so there is an emergency. Okay, so considering that, they have to plan the future thing.
Fine, correct. Maheshwari, you want to say something in this case?
No, sir.
Okay, fine, go ahead.
Local examination, sir, inspection, abdomen is globular, umbilical centrally placed, all quadrants moving equally with respiration, no flank fullness, no scars, sinuses, or engorged veins. Palpation, there is no localized of temperature or tenderness. Bladder is not palpable. Percussion is normal. Auscultation is normal, sir. External genitalia looks grossly normal. All hernial orifices are normal, and patient has urethral meatus. Patient is uncircumcised, and external genitalia is grossly normal. And for rectal, sir, prostate is only grade 1 enlargement, firm with smooth surface, non-tender. Rest all is normal, sir.
Yeah. Okay. So Yasir, now tell me.
Yes, sir. After this examination, I would like to investigate the patient. I will
So now,
start
first of
with,
all, tell us what is your probable diagnosis now.
so the diagnosis will be this ureteric stone with decrease in the urine anuria. Second thing would be, sir, PUJ obstruction due to stone with anuria. And third thing will be, sir, ureteric stricture plus this anuria, sir. And fourth will be distal obstruction, urethral obstruction with proximal hydronephrosis and hydroureteronephrosis and anuria.
Now, what I would suggest is, what is the more say important diagnosis among this, that is anuria. So the way I would have said this is that my diagnosis is anuria because of obstructive uropathy to the solitary kidney. The causes could be stones anywhere, strictures, or other causes.
I agree, sir. Because the important thing here is, as you say, important thing and very the thing which is emergency is anuria.
Exactly. So basically, you have to say it's a solitary kidney. You know, nephrectomy has taken place. So you know it's a solitary kidney, and since it is anuria, it is an obstructed system. And this obstruction, don't say that there is a stone in the paluretic junction, stone in upper ureter, stone in middle ureter, stone in lower ureter, stone in V junction. No. As Dr. Pankaj Maheshwari said, it's a solitary kidney with obstruction secondary to calculus disease, can be PU junction obstruction or stricture ureter.
So solitary functioning kidney, if you know how it usually presents when it got obstructed, is with either anuria, either with recurrent urinary tract infections, or renal insufficiency, or sepsis. These are the four terminal events in unilateral obstructed kidney. So sepsis, insufficiency, anuria, and UTI. Sepsis may be proximal pyonephrosis, infected hydronephrosis, rupture perinephric abscess, anything can happen. So these are the four pillar complication of unilateral obstructed kidney. One is the sepsis, another is UTI, third is renal insufficiency, fourth is sepsis. Anuria, sorry, anuria. So as per this, we have to go forward.
Okay. So now next what, Yasir, what you want to do?
Investigate. I would like to investigate the patient.
Yeah.
The investigations I would like to do is first routine CBC, renal function test, urine examination, routine urine examination.
Patient is in
And-
anemia.
Sir, I would like to first do an office ultrasound, sir, immediately in the
Perfect.
video.
Pankaj, you are saying something.
I said patient is in anuria. How will you do urine examination?
Yes, Yasir.
Yes.
Therefore,
No
after
problem.
examination of the patient, two important things. If it is obstructed and bladder is full, you have to place the catheter, the one important. Parallelly, you have to send the blood examination in terms of CBC, serum creatinine, serum electrolyte, and you have to go for radiological investigation in terms of either ultrasound or if you are feeling it is renal colic, then it is non-contrast CT scan. Primarily.
CT.
So this should go in hand, parallel.
So Yasir and Nikhil, please understand. See, you are not narrating what you read in your books. Okay. You are talking about this case. So Dr. Pankaj Maheshwari, if he is an examiner, see, he is very intelligent and smart to find out this point. When you are saying a patient is anuric, he is not passing urine, how you will send urine for routine examination?
Yes.
So your investigation or your clinical judgment should be towards the patient, not in general. You understand?
Yes.
So you must have that presence of mind. Understood?
Yes.
So this is very important. He has pointed out very important point that how can you send urine routine? So well, as Dr. Gite said, we will do the basic investigation. Achin, sure.
Yes. Respiratory system is normal.
Yeah.
CVS is normal. CNS is normal. CBC is 13,200. Hemoglobin is 11. Creatinine is 6. And sodium is 131. Potassium is 6.0.
Now, Devashish is asking, can we aspirate suprapubically? But when the bladder is not palpable, so how you are going to, first you find out whether he is making urine or not. No? When the bladder is not palpable, we are not thinking of in terms of retention. We are thinking in terms of anuria.
And Devashish, how will it help you at this time by getting a suprapubic urine?
Exactly.
And if bladder is full, you'll put a catheter. And
Precisely.
if you have gone through that stage of already examination is over, then if you ask this kind of question, it will piss off the examiner.
So, understood. So now next what? Yasir. It's
So, I will like.
And the sonography. They had asked for the
Sonography.
sonography. So ask about, show about the sonography.
Sir, right kidney cannot be visualized. Left kidney shows mild hydronephrosis with moderate hydroureter. Lower ureter cannot be visualized. And prostate is 22 grams. Bladder is empty, sir.
Okay. So Nikhil, question to you. Now these are the investigations. Now what you want to do?
Sir, so blood investigations, I don't know, sir, what is the create. At the same time, I would also like to do, because there is hydroureter nephrosis present for this patient, sir, and the cause is not known well in the ultrasound. I want a non-contrast CT, sir, for this patient investigation. Simultaneously, blood investigations also I'll send, sir, for what is the create level of this patient.
Creatinine level is 6.
Non-contrast 6.
Creatinine is 6.
Yes.
Yasir,
Yes, sir.
what you want to do?
Potassium is 6. Potassium is 6. I will also like to do the ECG of the patient.
Achin, show the ECG.
Yes, 2.
The potassium is 6 on creatinine, sir.
Both potassium and
Both.
creatine, both are 6.
Both.
I am showing this ECG which was there in your last exam.
Can you see the ECG?
This is not this patient's ECG. Okay. Now you get something like this. What is your diagnosis? Here it is given. Describe the ECG. What is the diagnosis? And what are the different steps of management in this patient?
I can't see the ECG.
Yes, Nikhil, answer.
Sir, I can't see the ECG. Not visible.
It's very bright actually.
No, like I'm only able to.
Nikhil, you cannot see it?
No, sir, I can't.
Come on, fast. We want to go ahead. Today, many
Your
cases.
friend is helping you. Wide QRS complex with tall T wave. Chalo, abhi bolo.
So what is the likely diagnosis?
Hyperkalemia, sir, it is finding. I'm not able to see the
Pardon?
hyperkalemia.
Hyperkalemia. So now, okay, Achin, go back. Now, what do you
Yes,
want
sir.
to do? How will you manage?
Sir, first is stabilizing the membrane, sir. So calcium gluconate 10% should be given, sir, initially for this patient. Hello.
This patient's ECG also at the same time.
Yasir, the last question was how we are going to manage this patient step by step. 3 steps they have asked in exam. This is the slide from your exam from OSCE, OSCE.
Okay.
You are given only 2 minutes. In these 2 minutes, you will not have so much of time.
So I will start with the calcium gluconate. Calcium gluconate, we give 10 ml of 10% calcium gluconate over 10 minutes, and followed by this is in a patient with ECG change, and followed by we will also give some regular insulin. Insulin we will give in 50 ml of dextrose, 50% dextrose, and
Yes, sir, theoretically, you should know the treatment of hyperkalemia, but if you are clear enough in exam, the answer is like this. I will immediately call the nephrologist for management of the problem and take his help.
yes, sir.
ओके ये हो गया प्रैक्टिकल का आंसर, लेकिन थियरी में अगर सेम क्वेश्चन आया तो तुमको सब चीज आना चाहिए.
So basically, mild.
So why you want, see, first of all, you will give a calcium gluconate. Why calcium gluconate? Because it's a chelating agent. What will happen? It will bind with the potassium and it will decrease the potassium.
Fast acting. Yes, sir.
Yeah. Second thing, you want to go give glucose with insulin. Why you want to give it? Because it will push
Insulin
potassium
basically causes into the cell.
So extracellular potassium will go intracellular, and it will again, because the extracellular potassium will have direct effect on the heart. Correct? Now the third thing is orally you can
Yes,
give.
sir.
That is a K-bind. That is again a chelating agent, but it will take its own time. Right? So this is
Yes.
a way you will
Yes.
like to treat the, and the last thing is, what is the next thing? If the still it is high, remaining high, what will do?
So exchange of plasmapheresis and
Dialysis.
Exactly. Fine. Okay. So now let us keep it aside now. Now this is the ultrasonography finding. Now next what you want to do?
So non-contrast CT.
CT scans.
You want to do CT scan?
Yes.
Yeah. Okay. Achit?
Yes.
Nikhil, why not directly non-contrast CT scan?
Sir, we can do sir non-contrast also directly, but in the OPD if he comes immediately, I would like to do an ultrasound to find out whether there is hydronephrosis present or not and what is the parenchyma. Ultimately, this is a non-contrast CT is required.
Okay,
So
see.
here, the right side kidney is not visible, sir. The left side kidney shows complete parenchymal thickness, where there is one hypodensity seen on the upper pole of the kidney, sir. And then there is a hydronephrosis present, sir, in the pelvis. It is dilated. The dilatation I can see following down. There is one radio density seen in the last cut, sir, in the kidney. I'm not sure about the size. And next cut. So there is one radio density seen in the parenchyma of the kidney. And one hypodense lesions are also seen, sir, on the parenchyma of the kidney, sir. The parenchymal thickness is good. More lower cut.
So you can see it.
Yes. The lower cuts, I want to trace either the coronal films or the lower cuts of the axial cuts. What I'm seeing is the axial cuts.
Okay, so now you tell us what are the positive findings you are seeing.
The positive findings is that there is good parenchymal thickness present, sir, for this kidney.
Other
And,
abdominal organs are normal, correct?
Yes, another abdomen. Yes.
Are you seeing the lower part of the chest? Is there any pleural effusion or anything in that?
Sir, in this cuts it is not visible. Yes. No, there is no this thing, there is no pleural effusion.
So it is, yeah, it is. You can
It
see
is,
lower.
yes, sir. It is normal. Mild amount of some amount of perinephric fat standing, I can see, sir, in this on the left side. Looks like inflammation.
So now you cannot see the right side kidney. The left sided parenchymal thickness. How is the parenchymal thickness?
Thickness is good, sir.
Then is it a hydronephrotic or fullness?
Hydronephrotic, sir, there is a mild hydronephrosis present, sir. It's a pelvis is dilated.
Perinephric fat standing is also.
Yes, sir, perinephric fat standing.
And then at the end you can see the stone in the lower ureter, correct?
Yes.
Oh.
Mid pool also there is stone. Mid pool of the kidney.
Show the other film.
So correct, now you have seen the CT. Now, like sir said, patient has come, he has got admitted, and you have given calcium gluconate drip, you have given glucose insulin, you have given K-band. Next day morning, you have repeated creatinine and electrolytes.
Yes.
And creatinine is again 6 and potassium is 6.1.
Sir, for this patient, I also would like to know the BTCT of this patient, so the coagulation profile. And this looks like a completely, because anuria is a completely obstructed system, so with stone. And no other pathology is visible here, and we cannot do a contrast for him. So initially, I would like to know the BTCT of this patient, sir, and the plan. So this thing is not coming down, sir. I can plan a diversion.
So okay, so Nikhil,
sir.
Now in this patient, what you want to do? Now you have started correcting his potassium. His creatinine is raised. His WBC count is 13,600, and this is the CT scan finding. Is absolutely anuric. What do you want like to do?
Sir, I would first put the patient on higher antibiotics and get a BTCT profile of this patient, sir. And then I would initially I would do a diversion procedure, sir, in the form of PCM, sir.
Yasir, what you will like to do?
Sir, I would like to do the BJ stenting.
Okay, so I will ask you both of you one question.
Sir.
What are the indications of doing dialysis in acute conditions? I'm not talking about end stage renal disease where we do dialysis. Okay, in acute condition, which are the indications?
Sir, in acute
After
conditions,
you answer sir's question, both of you justify why
Yes.
PCA and why DJ stenting.
Okay. So the acute condition is like one is the solitary functioning with kidney with anuria and hyperkalemia is present, then this patient will qualify for for dialysis.
So what are the indications of dialysis?
One is a hyperkalemia with a decreased amount of urine output. Sir.
Yasir?
Sir, anuria, electrolyte imbalance like hyperkalemia, hyperphosphatemia, this intoxication, volume overload, pulmonary edema,
See the one of the clinic.
and uremic encephalopathy, sir.
Urosepsis.
In one of the clinic, it was said AEIOU. अपना doctor, I forgot his name. Gite sir, किसने बोला? Maheshwari. Who had told about that?
Sharma sir, I think. Sharma sir.
No, not Sharma. अपना, I forgot it.
Transplant wale.
Yeah.
Deshpande.
No. So A for anuria. Okay, absolute.
Yes.
E is electrolyte imbalance. I is infection septicemia. Okay, O is overload, fluid overload, and U is uremia. So these are the 5 different conditions where you will do emergency dialysis in acute condition.
You forgot urosepsis. I just added it. So sir also told urosepsis. That should be added always.
Okay.
When the unstable patient with all these things, you will want to do dialysis.
Okay.
Yes.
So these are the 5 indications. Fine. So in this case, Nikhil is saying he will like to do PCN. Correct, Nikhil?
Yes.
Why you want to do PCN? What are the advantages and what are the disadvantages?
So the first advantage is that it will decompress the system, sir, and it will provide an outlet for the urine to come out. That would be my first thing because patient is anuric. Second thing is that, sir, PCN I would prefer over venous stenting because it is an obstructed system and already there is I am suspecting there will be edema around this thing, and to push the stent into the system will be a little difficult to negotiate the stent into the system. If you blindly push it, there are chances that it may go out of the system also. So
I would be happy if you said that you will do something which is safe for the patient. So
Nikhil,
PCN is correct, and that is you should be safe with the patient.
What you are planning is when there is a you have to force to do it, then only it is okay. Here, solitary functioning kidney. If you know exactly what happens in the solitary functioning kidney, it is like a congenital single kidney. It already 8 saal ho chuka hai.
Yes.
So there is a compensatory hypertrophy.
Yes.
Okay. Whenever there is a compensatory hypertrophy, more cortical thickness. Whenever there is a more cortical thickness, there are chances of having a more vessels along the pelvic system. So there are more chances of getting the bleeding. If you try to puncture the kidney, this is the basic anatomy.
Yes.
Okay. Here, your ultrasound doesn't show any internal leakage inside. Your CT scan doesn't show any perinephric collection. Any stone obstructing at the PUJ, stone is at the VUJ. So if you say like, I will try for the DJ stenting, and if wire is also not going, then you don't have any other option than to place the patient. DJ stent, a number of places people are doing under local anesthesia. Scopy under local anesthesia in adult. Okay, shadow anesthesia, another more safer anesthesia. Local anesthesia, shadow anesthesia, try for DJ stenting. What is wrong in that? Why not DJ stenting? Why directly PCN, solitary functioning kidney, large cortical thickness, chance of bleeding is more, no pyelonephrosis, no internal leakage. So tell me why you are choosing the PCN over the DJ with this background.
Sir, because I don't want to do anything blind in this patient, sir, because it's
why who told you DJ stenting is blind? You are placing the stent under vision, fluoroscopy guided. If wire has gone, ureter catheter has gone, you just placed 1 cc, 2 cc contrast, check it is inside the system, everything is under vision. Na?
Yes. Fluoroscopy guided.
Huh.
Yasir, what are the advantages
Yes,
of
sir.
DJ stenting and disadvantage of DJ stent?
Uh, the advantages, advantage is that at the time of putting the digestant, we can completely go for the removal of the stone also. First, after, before doing the stenting. If not able to pass and clear the stone, then I would like to do the digesting. So, second, the disadvantage is that sometimes we will not be able to put the digestant from down, maybe due to some stricture or other causes around in the ureter.
See, both of you na, are just half-heartedly you are answering, Nikhil. So just suppose now Dr. Gite has talked to you about this case. So in this case, because it's a solitary hypertrophic kidney, there is not much of the hydronephrosis, right?
Yes, sir.
Now PCN will be
Difficult.
little difficult. Not only that, there are chances of bleeding and complications. Okay.
Yes.
So in this case, you may go for a digestant. But suppose otherwise, what are the advantages? Just in theory, if you want to write down, then what are the advantages of doing PCN? Just narrate 1, 2, 3, 4, 5, 6.
Paran bhai, can I come in between?
Sir,
Yeah, please, Pankaj.
Yes. So Nikhil, you know, when Gita Saab
we
told
can-
you all this, you are not supposed to agree with Gita Saab. You are supposed to defend your PCN.
Okay.
Examiner will always say opposite of what you are saying. Okay. So how will you defend PCN in this patient? Gita Saab has given you disadvantages of PCN.
Yes.
You see, what if I was in your place, I would say that I would do PCN because one, it can be done bedside under local anesthesia.
Yes.
We do it under sonography guidance. And the best thing to say in exam when you get cornered is that it is our institutional policy. Okay, that will take care of a lot of problems. कि हमारे यहाँ ऐसा करते हैं. There is nothing wrong in that. Okay. And finally, what you said was also absolutely right, that seeing the stone on CT scan, seeing the inflammation, you can nearly see a pseudo-ureterocele in the CT scan image. This is a sign that degestenting is likely to be difficult in this patient. So don't, once you say something, unless you have said something grossly wrong, don't agree with the examiner. You are supposed to try to defend your position. So like when you say PCN, we will talk of digestant. When the other doctor talks of digestant, we'll talk of PCN. But we expect you to defend what you have said.
And like I said earlier, sir, he has to be safe with the patient. With a potassium of 6 or whatever, he can safely place a PCN, allow the patient to settle,
Yes.
and then take for a planned procedure. What if the patient has a cardiac problem on table? How will you defend yourself?
So
In
by
real
doing
life also.
PCN, you are not doing anything wrong. You see, literature is flooded with references which say that both have
Both are-
practically
yes.
equal things. And in this patient, one more point I would say is because the total count is high, I am suspecting infection. Now,
Exactly.
Gita Saab told you that there are no internal echoes. Does every say pyonephrosis need to have internal echoes? So you can still find infection without internal echoes. So this is what is expected from you, not agreeing with the examiner.
So understood, Nikhil. So
Yes,
the
sir, yes,
advantage,
got it.
why you, so first of all, what are the advantages of PCN? Number one, and why in this case you are preferring PCN? These are the two important things. So
Yes.
the advantage of PCN, as Dr. Maheshwari has said, you can do under local anesthesia.
Yes.
It can be done at the bedside.
Yes.
Third thing, when you are calling these sonologists, he can also do a Doppler and can see where there is a less vascular area, and he will put the drain through that. Then if it is infected urine, the external drainage is better because it is bigger. In case if there is a stone in the upper ureter or in the kidney, later on you can use it as a
PCN
to do the PCNL. You can measure the amount. Suppose that from that kidney how much urine is coming. Of course, this is a solitary kidney, so even the per urethral when you do the digesting, you'll come to know the how much urine is coming. So these are the important things. And how you are going to define? Number one, as Dr. Maheshwari said, bedside, local anesthesia, patient has got high WBC count, so there are chances of infection. There is a edema, as you can see in CT scan. It will be difficult. Potassium is high. I don't want to take any chances and give anesthesia and invite the trouble. So these are the answers. You must defend yourself. Okay?
Yeah.
Yeah. So Yasir, how you are going to? I'm telling you, Dr. Gite, Dr. Maheshwari is telling that PCN is better, and you are saying digestenting is better.
Yes, sir.
What are the advantages of digestenting, and in this case, why you want to do digestenting?
Sir, I will basically, I'm going for
So
the
first, tell me what are
digestion.
the advantages of digestenting? 1, 2, 3, 4, 5.
The nephrostomy drain is not there. There are less chances of if after the surgery there are less chances of infecting the calcium system because the kidney is solitary. I don't want to puncture and just decrease the renal function. So
Okay.
digestenting, we can save the basically the renal loss that we will get in the PCN. And plus after
Now
if
the question
we
is,
fail,
how
if
much is
we
the
fail,
renal loss in PCN?
Yasir, listen to Dr. Pankaj Maheshwari. Pankaj, tell him again.
How much is the renal loss?
Sir,
in
what the
PCN?
question?
Cashier,
Sir, don't have any idea.
if you want to defend the digestion, you have to tell exactly what they have taken for patient. Okay. So
Yes, sir.
digestion is internal drainage. If digestion doesn't go, you have to go for patient. Another alternative
Yes,
is
we
patient
have
only.
another choice.
So it is internal
Yes,
drainage.
sir.
Can be done under local anesthesia. Okay. Then as
Yes,
there
sir.
is mild infected hydronephrosis may not be the indication for draining the patient until otherwise there is a thick pus which is not drained by the tube inside. Anyhow, the internal drainage is aside of the digestion, not through the digestion. So internal drainage, if it is done under local anesthesia and if train goes, it is better. No, कुछ बैग हाथ में बैग भी नहीं आएगा.
Yes, sir.
ठीक है.
Digestion can also be done
उसका
in
sleep
local anesthesia.
It's
slippage
interesting. The
of the
answers for both
patient,
are nearly the same.
bleeding,
Yes, sir.
bleeding, peripatient leakage, slippage of the patient, difficulty in sleeping, morbidity of the patient. And as there is no gross pyonephrosis, any report, radiological report suggests a pyonephrosis. Infected hydronephrosis is equally drained with patient oblique disease. So choice is yours. So why I don't want to go for patient in this patient, solitary functioning kidney, compensatory hypertrophy. See the cortical thickness. Then how will you puncture the kidney? Mild hydronephrosis. Then you have to do the blind puncture. Needs expertise. Needs sonography assistance. Even if for sonologist, puncturing the mild hydronephrosis is difficult. So that's why I'm planning for digestenting. And in spite of that, if examiner is teaching for patient, professor, if digestant is not doing, then patient can be done as another alternative. Why not primarily patient? अगर examiner वहीं पे stuck हो गया है, तो बोल देना है कि sir patient can also be done. 2 बार defend करने की कोशिश करने का, तीसरे बार को उसको accept कर देना.
Fine. Okay.
For
Yasir.
examination.
So you can always say that, sir, I can digestion can be easily done under local anesthesia. Number 1. Number 2, it is an internal drainage. Number 3, if after keeping it, the URS will be very easy because edema and everything will go away. And in this case, I will differ in doing PCN because it's a solitary kidney, hypertrophic kidney, chances of bleeding are there. This bleeding may cause obstruction and the drainage may not be there for 1 or 2 days. So that is the reason I want to do. So you can justify your,
So,
okay?
so for me, the decompression is important here.
Yeah.
You want to do internal decompression or external decompression is your choice as per your protocol, as per your institutional protocol, whatever you have taught, whatever you are doing, वो चलेगा. लेकिन decompression important है. पैसा करना वैसा करो. Internal करो, external करो, decompression होना जरूरी है.
Yeah. So, Nikhil, you will not like to do dialysis in this case. Patient has got 13,000 count.
Yes.
Patient has got hyperkalemia. Patient has got raised creatinine of 6. So why you don't want to do dialysis in this patient?
Sir, in our institute, sir, if it is obstructive uropathy, they initially advise us to make a diversion and then they quantify the amount of urine output.
No,
whether
why
it is,
you don't want to do dialysis in this patient? I'm saying these are not an indication to do dialysis.
it is an indication, sir, to do dialysis. Yeah,
But are they
hyperkalemia.
absolute indication?
Sir, I'm not very sure, sir.
So, okay, the next question is, when you put a digestant, what will happen? Or when you do PCN, what will happen?
It will decompress the system, sir. We can quantify the amount of urine output that the kidney is producing. So we can quantify, sir, and there are chances that his creatinine level may come down. We'll know whether it is oliguric this thing, sir, or non-oliguric.
No, you are not getting my point.
Sir,
Yeah.
I am leaving, sir.
Okay. Join in
Thank
between
you.
when you get a time.
Yeah. Thank you, sir.
So, okay. So, Yasir, can you answer? See, otherwise the patient, you can always say that patient is stable. Correct?
Yes.
The ECG, as you have done everything, ECG is not showing any arrhythmias. You have already corrected potassium. So in this case, you can go ahead and you can do surgical intervention either in the form of PCN or digestanting. And after that, there will be what? Diuresis.
Yes, the post-operative dialysis.
Post-obstructive diuresis.
So what will happen in that?
Sir, post-obstructive diuresis, we'll have to see whether it is more than
So how
24
much
hours.
urine will be formed?
Sir, it will be more than 2000 ml per day. Or
How
the
much?
rate of production, 2000 ml per day.
More than
3
2 or
liters.
2000 is called diuresis.
No, sir, the rate of production is more than 200 ml per hour.
200 ml per hour, na?
Yes.
Fine. So how much urine in 24 hours?
In 24 hours, it will be more than around 4,800.
Exactly. So
Amen.
it should be more than 4,000 to 4,500. Then it is a diuresis. Fine. So this patient, and how fast the creatinine will come down?
The definition of post-obstructive diuresis is more than 200 ml per hour for more than 2 hours.
Again, Pankaj, come again.
More than 200 ml per hour for more than 2 hours.
Okay. So please remember all of you.
Yes.
So, okay. So now after that, what we will do? So you have done a digestanting.
Yes.
So Nikhil, you are going to do digestanting, correct?
PCN.
You are going to do PCN. So you have done PCN. Now next what?
After PCN, I will quantify the amount of urine output, sir, for this patient serially. Every hourly urine output I will measure and also in 24 hours. And then every day I would like to repeat 24 to 36 hours. I would like to see how much the creatinine is coming down, sir, and with electrolytes.
But now you are getting urine.
Sir.
You will not like to do something
Sir, I will like to send the PCN fluid analysis also.
for
for the functioning status of the kidney, sir. Like it is in the which phase?
But
Post-obstructive
as you
diuresis.
said that initially there will be diuresis.
Yes, sir.
So this urine you want to send for what? Dr.
Urine
Maheshwari
we can
told
send
you in the
for,
beginning that you cannot
routine-
send urine because
urine
this is
routine.
anuric.
Routine we can send, sir, and for culture also you can send.
Exactly. So you like to send. So first thing what you will do is collect urine and send it for culture and sensitivity. That is the most important thing. Na?
Yes, yes.
So always remember that.
Correct.
Okay.
Yes, sir.
So then now you patient is draining, as you said, diuresis, and he is draining more than 3 to 4 liters
Yes.
for first 24 hours, and then steadily he is passing 2.5 liters.
Yes.
So now what you will do?
So we'll simultaneously see how much is the creatinine value of this treatment, sir, coming. And meanwhile, we did not get this thing, sir, the CT report of this patient. So we like if the patient is improving, if all the parameters are coming well based on the CT report, like report is available. So on this, we'll plan a definitive treatment, sir, for this patient.
So how many days you are expecting?
So this diuresis phase will last for pathological diuresis phase will last for about 1 week, sir.
Diuresis will last for 1 week.
Physiological will resolve in 24 hours, sir. If it is pathological, it will take around 48 hours.
Yes. Okay. Fine. So when you are expecting creatinine or all the parameters to come down to normal?
Sir, in 2 to 3 days, sir.
Okay, maximum 7 days. Fine. So after that, what you will like to do?
So based
Now all
on
the parameters are okay. Potassium, sodium, creatinine.
yes, sir.
That is, you have covered the infection with higher antibiotics. The patient is stable. So what
Yes.
do you like to do?
So then I would like to plan this patient for a definitive treatment, sir. Here he's having in the report they're showing as VUJ calculus present, sir, for this patient of about 9.3 mm, sir. With
Yeah.
hospital unit of 850. So I would like to take up this patient for ureteroscopy stone removal.
When are you planning the ureteroscopy?
So one,
1 month.
no, sir. Once the patient is stable, sir, then after a week, if everything is normal, sir, in 2 weeks, 1 to 2 weeks, I will take up this patient, sir.
Why do you want ureteroscopy? Why not conservative treatment?
Sir, he is a solidly functioning kidney, sir. So I don't want to leave this patient with a conservative expectant management of possible
But you have
passes of
already
stone.
placed a stent.
I have placed a PCN, sir, so I have not done anything for the stone as such.
Fair.
So, Maheshwari,
Yes, sir.
normally, how many days you will wait? 7 days to 2 weeks?
No. I wait minimum 2 weeks, sir. Once we have placed a stent oblique PCN, then there is no hurry to go in a second stage, especially when the creatinine was 6 and total count was raised. So I would wait till the creatinine stabilizes, till the infection completely stabilizes. I document culture free, negative culture status, and only then plan the next step.
Fine. So, Yasir, your answer is also the same,
Yes.
correct? Because you have put the digestant, so you like to wait for at least 1 week to 2 weeks till all the parameters come down to normal. Patient has taken enough of antibiotics covered, right? And then you'll go inside and you'll do.
Yes.
So now Dr. Maheshwari asked you this question that you have placed the digestant. Will you like to give a conservative line of treatment? Do you think that stone will come out on its own?
Yes, sir, there are chances that the stone can pass. But being a solitary kidney, if on the repeat sonography the stone has not passed, then we should go for the intervention.
Do you think so?
Yes, sir, because the DJ stent is inside, so there are chances that the stone can pass.
No, we should go ahead. It's a solitary kidney. Stone is more than 6 millimeter. So you have to go inside and remove the stone. Okay. Fine. Pankaj, you want to say anything else?
Yes, yes.
Otherwise, we'll
No,
go for the next case.
what you are saying is absolutely right. But as per the recent guidelines, they have said that stones up till even 10 millimeter can be attempted conservatively. But I agree with both of them that because this is a solitary kidney,
Yeah.
and patient has already landed into anuria, definitely the aim will not be to try conservative. But yes, there is a theoretical possibility that stone may slip in bladder in the 2-week period that we are waiting.
Right. Okay. So this is the answer. In case if the stone is 4 millimeter, 5 millimeter, you have done a DJ stenting, it's not a solitary kidney. You can always say that I will like to wait, I will remove the stent, and there are chances that patient will pass away or a stone. Okay.
Yes.
Right. So, Pankaj, we are going. Hiren, you are there, na? So, Pankaj, we are going for the second case.
Yes, sir, I'm here.
So we are going for the second case. Now the next, all the cases will just have a short history. We will not discuss about their history. Okay.
Yes.
So this was the post.
Before we proceed further, sir, one last thing, few comments that I would want to make here, that whenever the patient has a solitary kidney, it is important to talk of metabolic evaluation post-stone clearance. It is extremely important to get a metabolic evaluation in this. And then you will also...
And even the analysis of the stone, correct?
Yes. So metabolic evaluation would include stone analysis and the blood and urine work. Okay. This would be done couple of weeks after stent removal, once you have documented again that there is no infection. And this is one patient where again you would give a very strict dietary instructions, fluid management instructions, and a follow-up protocol.
Yes.
Nikhil, Yasir,
Yes, sir. Yes, sir.
You understood? This is the most important thing.
Yes.
Dr. Pankaj Maheshwari has given you what you should say in exam, because these are the things we forget. We think that we have done the surgery, we have removed the stone, and our job is over. No, our job is not over. You have to conclude and you have to say all these points.
Yes.
Pankaj, thank you.
Thank you, sir.
So let's go for the next case.
Sure.
Yeah. Yeah, we show them. Just show them what was the analysis.
So the creatinine came down.
Creatinine had come down. Okay.
Yes.
1.1.
Yes.
Fine. Okay. Next case.
There are a gentleman, 59 years of age, Muslim, resident of Mumbai, shopkeeper, came with complaints of right lower abdominal pain since 1 month.
Yeah. Go ahead. What are the this thing? Yeah.
Patient was apparently asymptomatic 3 months back when he started developing right lower abdominal pain in serious in onset, gradually progressive, dull aching, intermittent in nature, relieved by medication, no specific aggravating or relieving factors, non-radiating type, no positional variation. There is no history of any nausea, vomiting, fever, lithuria, hematuria, trauma, no history of any facial
Just go ahead, Achin.
Yes, sir.
Just tell them what is the investigations.
Patient is a known case of diabetes mellitus and hypertension.
Yeah, and the past history, patient had undergone
history of right
assisted PCNL in past.
Yes, sir.
Okay, fine. Go ahead.
Just
go ahead. Show them the. See, all the investigations are normal except that serum creatinine is 1.94. And urine is showing pus cells 80 to 100. Okay, Nikhil.
Yes, sir.
Just tell us what is the X-ray is showing.
Sir, it's an X-ray KEB film that we are seeing here, and the positive findings is like there is a radio opacity that is seen, sir. The level of lower ureters, the level of lower ureter we UJ region, sir. Here on the right side.
Come again, what did you say? Level of?
Sir, it's a level of sacral promontory, lower vertebra, and on the right side it is seen, sir. And if we correspond this to the ureter, then it comes to the level of lower ureter.
Again, while describing X-ray, you have missed so many important points. You have not commented about whether the X-ray is well centralized. How is the preparation? Are you seeing the soft tissue shadows? Is the exposure good? How is the bony landmarks? Then you go to the stone. Na?
Yeah.
I'm not seeing any renal outlines here. Have you shown
Can you
me?
see the renal outline here?
Not very well, sir. I cannot properly make out. I cannot.
So, okay, Nikhil, continue. So, where do you think is the stone?
Sir, I'm not sure whether it is shown. Some radio opacity is seen, sir, on the distance at the level of the L5 vertebra.
Yeah, but L5 will be much higher. Na? This is the junction of mid and lower ureter. So, L5 will be much higher. So, what are the other possibilities? Say, if we consider this to be a stone, what are the other possibilities?
What are the other DDs, sir? I didn't get it.
One, you have said that this could be a stone in at the junction of mid and lower ureter.
Yes, you should get the hint. He said there was a past history of lap assisted PCNL.
Okay. Then this could be a low-lying kidney, sir. It could be a pelvic kidney with low-lying kidney, sir. One that could be one.
Do you have any proof of? Do you have anything which would suggest that this could be a pelvic kidney?
In X-ray, we cannot make it.
Yes, you can.
The renal outline, sir.
So you see, the colon has come quite medial here.
Yes, sir.
Okay. Otherwise, you would expect the colon to be much lateral.
Lateral, right.
The medialized colon means that probably the renal fossa is empty. Further, if you look very, very carefully, you can see a circular slough which is covering the lower two vertebra and the sacral promontory. Maybe I am overreading things, but these are things I can see here. I don't know whether you can see my arrow, but yes.
Yes, I can.
So, and this colon has come very medial, which is a sign that the renal fossa is empty.
Nikhil, Yasid, it's such a beautiful one X-ray, and Dr. Pankaj Maheshwari has shown you so many things. So this is very important. You should not be dependent on CT and other investigations. So whenever you see even the primitive investigation, you should know many things.
This can only come if you go in a routine way of reading the X-ray. If you directly jump to radio opacity, certainly you are going to make a mistake in the exam.
Absolutely.
Okay.
So
fine.
the outline of left kidney can be made, no?
Yes, you can see the left kidney here. The outline is seen here.
Outline.
Maybe. Okay.
Maybe,
Sure.
yes.
So now, Nikhil, next
Yes.
what investigation you like to do? We have already gone into the detail of one case.
Yes.
So in this case, what next?
So CT, sir. Non-contrast CT.
CT scan,
Yes, sir. Non-contrast.
non-contact. Okay. Just show. So the sonography you don't want to do, na?
So, sir, CT is more because there is radio opacity there. So I would like to do.
Okay. I think you are Pankaj is justified na, in saying directly.
Absolutely, sir. Once we have done the X-ray and it has shown a large stone,
Yeah.
we can directly skip unless as a protocol you do sonography as in your office sonography.
Yeah.
It is not needed now.
Okay. Just show the result of sonography.
Both kidneys are not seen in either renal fossa. Evidence of 11.6 into 7.7 centimeter kidney-like moiety seen in midline of the abdomen with mild fullness of the PCS with 16.8 millimeter calculus in the right side. Urinary bladder wall is mildly thickened, suggestive of cystitis. Prostate is 23 grams.
Fine. So, okay. So now show the CT scan. Can you just zoom it?
Zoom.
Fine. So now you know both of you know what is ultrasonography is showing, and now what is this CT scan. So tell us, what is the diagnosis?
The diagnosis is the horseshoe kidney is there, sir. The lower poles of both the kidneys are fused, sir.
Yasir, what is your diagnosis?
The
Where are the kidneys?
right
Kidneys are low lying.
kidneys and the pelvis only.
Any part of the
Low-lying.
kidney is seen in the abdomen?
No, sir.
Nikhil?
Yes.
No, sir.
No.
Then, so what is your diagnosis? Can you say it is a horseshoe kidney? Where the
Yes.
horseshoe kidney, the lower pole will
No,
be?
sir. Horse.
Pardon?
The level of L4, L3, sir. The next,
Okay.
next bit, sir.
Where the lower pole will get obstructed?
Right below the inferior mesenteric artery, right, the level of L3.
So where it comes?
L3, sir. Below L3.
Isthmus, yes, isthmus.
So what is your diagnosis now?
Sir, it's a case of refused this but expert.
Achin, just show them the diagnosis. Just write down. So
Both kidneys are fused with each other to show morphology of a horseshoe kidney located in the pelvis just inferior to the bifurcation of abdominal aorta. 2.3 centimeter calculus noted in the proximal ureter of right renal moiety, causing mild hydronephrosis on right side.
Yes.
So this is also horseshoe kidney with this calculus on the right side.
no. Come again. What you are saying, Yasir?
The horseshoe kidney with 2.3 centimeter stone in the right kidney. Sir.
Are you sure it is a horseshoe kidney?
So there is
No,
fusion.
sir, I'm not
sir.
sure. Saying the CT, I cannot make that is a horseshoe kidney, but the report is saying that otherwise I cannot differentiate between the right and left side.
Both
of
the
Do you have
kidneys are in the
coronal
pelvis.
reconstructions?
Sir,
I
coronal
cannot
image
make
is
out
not
the sir,
available.
left and right pelvic axial system on the right and left side because in horseshoe only the isthmus is that's the lower pool is only fused. But on this CT, sir, I'm not able to.
Have you heard about when the both
Pelvis
the
is
kidneys are
anterior
in
to
the pelvis and they are fused? It is called
Yeah, it is this
it is called
the
pancake.
medial both the
Pan-
medial sides
pancake,
pancake.
biscuit.
Yes, sir.
So this is a pancake kidney,
Okay.
and there is a stone in the right pelvis. So now in this case, this patient has undergone earlier also
PCM.
PCM,
Lapis.
laparoscopic assessment. Now in this
Laparoscopy.
case, that time that was about 15 years back, where we didn't have many instruments. Now, in this case, what you like to do? Nikhil, first you answer. What do you like to do?
Sir, I would like to first get a renal angiography for this patient, CT angio.
Why you want to do CT angio?
So there is a lot of anomalous artery that can occur, sir, in such a condition.
So now what is your plan? What you want to do?
Sir, I would like to go with lap-assisted PCNL.
Okay. Yasir, what you want to do?
So I would like to do the retrograde method. I would like to do the ureteroscopy followed by the RIRS.
Okay.
But-
Pankaj, what they should answer?
The size of the stone is 2.2 centimeters.
Yes. So with the large size of stone, I don't remember the Hounsfield unit, what they have said. And with the reduced function kidney with creatinine 1.94, we don't expect it to be a normal functioning kidney. PCNL will be a better option. RIRS, I would consider only if the patient is on antiplatelet agents which cannot be stopped. But otherwise, the higher possibility of making him completely stone free would be by PCNL. And because this kidney is present in pelvis, the only way PCNL is possible is by laparoscopic guided PCNL.
So since you said RIRS, tell me 2 or 3 things. One, how will you counsel the patient? 2, what are the special precautions you will take in this case? And 3,
so
what
first-
instruments you will have?
First thing that I would like to counsel the patient is that I can basically, after doing the RIRS, basically I cannot reach up to the kidney because the ureters are highly placed. So I may have the chance to convert it into the lap-assisted PCNL. So second thing, I can counsel the patient regarding that if I'm able to do the PCNL, I may not be able to remove all the stones. And there may be some residual stones for which the patient has to be ready for the next sitting. And before these two, I may explain the patient that I may not be able to go and do the PCNL.
PCNL or RIRS? I said, how will you counsel the patient for RIRS? So you said, okay.
I'm not able to go RIRS.
Correct. So first thing, see, I asked you 3 questions. First was, how will you counsel the patient? So you have to tell the patient that RIRS may be challenging and you may not be able to reach the stone, or the ureter may be tight and it can cause a failure. In that case, you should counsel them also for a lap-assisted PCNL.
Or a 2-stage procedure.
Second, if RIRS is possible, you may do it in stages. Exactly what sir is telling. This thing you have to counsel, or you have to say that if RIRS I am not attempting, I may do lap-assisted PCNL, also maybe in stage. Second, what are the special precautions you will take for RIRS? What can happen in this RIRS?
Because in this case, anatomy will be a difficult one. So the ureters will be highly placed, or the ureters can be tortuous, and I may not be able to pass this RIRS scope.
So because of the challenging anatomy, you have to be careful that you don't perforate. Okay. Secondly, because of the challenging anatomy, the stone or the calyces may be anteriorly located. So even though you reach the kidney, you may have a challenge in finding the stone. And even if you find the stone, there may be a challenge in touching the laser to the stone. These are practical problems, it happens. Third, if you're doing RIRS, what special equipment you will keep?
I would like to give the access sheet.
So you should have, one is try to arrange the disposable scope because it is lighter in weight and you will be able to maneuver it better. Second, you may have a ureter scope with channels at 2 different places, that 3 o'clock and 9 o'clock, like in FlexX 2S and FlexX C, because sometimes in one position you may not be able to reach the stone. And third, you need to have a special access sheath, at least 28 centimeters. Smaller than that may not be available, but at least you should have that. And small DJ stent.
Yes.
Right.
So to conclude, in this case, because I only had done lap-assisted PCNL earlier, we were little worried that there may be adhesions and we may not be able to reach to the, because it is a pancake. So we decided to do first RIRS, telling the same thing to the patient that if we are not successful, we'll go ahead. But as you can see, Dr. Pankaj Maheshwari has also said it's a large stone, correct? Second thing is a hard stone, right? It's a roomy pelvis. Now, whatever Hiren is saying is a very roomy pelvis. Again, it is anterior. So the stone keeps on moving and we are not able to reach to the stone. So we tried URS because it was very hard. It was taking a long time. We were not able to reach to the stone many times. The laser was not reaching and we were not able to break the stone. We went ahead to do lab assisted PCNL. Okay, fine. So as you can see, it is totally covered with the intestine. So we have to do adenolysis and then. So what are the, Yasid, what is the most important thing you will do in pelvic kidney?
Sir, head down position and
Okay, so important thing, head low position. Okay, fine. Second thing is,
While dilating, what precaution you will take, sir is asking.
so under CM, see, most important thing, there are chances that you may not be able to puncture the calyx because number one, the calyx, because you are going from anterior aspect, correct?
yes, sir.
And the calyx, you cannot see in PCNL, you may be able to go to a particular calyx, but here it is very difficult to go to a particular calyx. So there are chances. And the second thing, calyx, they are very blunt. They have got a short and large infundibulum. So like the whole pelvis appears like with a multiple small calyx around. Okay. So sometimes you might have to directly puncture the pelvis also. Okay. So that is one thing. Second thing is during dilatation, once under vision, you have punctured the kidney, you have passed the guide wire, you have done the Teflon dilators. Now what? So what is the most important thing you will do?
Dilatation of the trial.
Pardon?
So dilatation of the trial.
Yeah, but during dilatation, the abdomen is totally distended.
We will say
Right or
try
wrong?
to decrease the pressure so that the distance between the kidney and the abdominal wall is less.
So you keep it such a low level that you can just see that intestine is not coming in the way. And
yes, sir.
The abdomen should be deflated and then only then you do the dilatation and do. Okay. So Nikhil, after the, just to show them, we have done the PCNL, we have removed the stone. Now next what? What are the things you will do? So tell us. You have done a PCNL. So now what you will do? See, we have deflated abdomen and we are doing the dilatation. Okay. So next what? We have done a PCNL, you remove the stone, you have put the small size digestant inside.
Nephrostomy drains.
Yes, it tell us.
So nephrostomy, keeping a nephrostomy, and that's actually the surgeon's choice, but I would like to put the nephrostomy drain and the abdominal.
Of course, you'll put the nephrostomy
and abdominal drains.
Yeah, so you'll put the drain. So now you've got a police catheter, you have got the nephrostomy, and you have got
Abdominal drain.
Abdominal drain. So how will you remove it?
First, I will like to remove the abdominal drain.
Abdominal drain.
Yes, sir.
Nikhil, you are
Yes, sir.
muted.
Yes, sir.
Okay,
Now, yes.
So Nikhil, you tell me what you will remove the first?
The drain, nephrostomy tube can be removed, sir.
Okay, so first you will remove the nephrostomy.
Nephrostomy, yes.
Then
After that,
Abdominal.
yes. After that, if the drain, nothing is coming, sir, then the drain can be removed and Foley can be removed.
okay, second Foley's catheter. Then
Yes. Then abdominal drain.
so you'll how many days you'll wait or how many hours you will wait?
The nephrostomy tube will
No,
wait.
nephrostomy you are removing. Yes, we remove after 48 hours. Then
Yes.
nothing is coming. You have removed the
Foley catheter after 1
Foley's
day.
catheter. Okay, after that, how
Foley's
many
catheter.
hours or days you will wait?
Sir, we can remove the drain in 2 days, sir. Max.
So in 24 hours, if nothing is coming, you
In
remove
24 hours. Yes, sir.
again. Correct?
Yes, sir.
Fine.
Yes.
Okay, so we did. So this is all. So Dr. Pankaj, this is the second case over. You want to ask anything more about this?
No, sir, I think well covered.
Okay, these are the just cases we are keeping because either in practical or in exam, when they come across such cases, they can immediately
Sure.
answer. They will not get lost. Okay, Achin, third case. So now in third case, Yasir and Nikhil, I want to tell you that we have not done as per a protocol, or maybe we have taken some shortcuts. Okay, so I will tell you what we have
Yes.
done, and you have to answer and you have to tell us what you will like to do. Don't think that
Okay,
what we have done is correct.
Okay.
And right. So this is the history. So
Yes.
the
Lady-
patient had my left flank pain since 1 month. Okay.
Yes.
And we okay, Achin, go ahead.
Patient was apparently asymptomatic 1 month back when she started developing left flank pain in serious in onset, gradually progressive, dull-aching type, intermittent in nature, relieved by medication, no specific aggravating factor, non-radiating type, no positional variation, and no issue of nausea, vomiting, fever, burning, mutilation, lithuria, hematuria, trauma, no issue of any facial puffness, lower limb edema, exertional dyspnea, no issue of any alerts. Past history, no issue of any diabetes, mellitus, hypertension, everything is negative. And general consumption patient is normal, comfortable, nothing abnormal. And abdominal examination is also normal only. Hemoglobin is 11.9, count is 9,700, creatinine is 1. Urine routine micro shows WBC is 2 to 4 per hyperfield and RBC is absent. USG film is not clear actually.
Just read the report.
USG shows the right kidney 11 by 4.9 centimeter, which shows mild dilatation of the PCS system with upper and mid ureter secondary to a large calculus measuring 9.8 millimeter, impacting the lower 1/3 of the ureter. And the left kidney reveals a calcium calculus measuring 9.6 millimeter in the lower pole without any focal calculasis.
Fine. Yasir, question
Yes,
to
sir.
you. Okay, this is a case.
Yes.
What we will like to do? Patient has got a pain. And he has off and on. Now the patient has come to you. Patient is saying,
Patient
I
was-
don't want surgery.
Okay. So the pain was on the left side only.
Yeah.
Pain was on the left side and left renal stone and right ureteric stone. They mentioned as USG. However, there is no
Right side
specific
ureteric
comment about the left ureter.
So I will basically like to investigate do at least the CBC, RFT, and then accordingly decide.
Everything is done. Now you know everything. This is a sonography is showing.
Non-contraceptive. What is the hospital? Patient doesn't want surgery. So what is
Creatinine
the
is
hospital?
normal.
So how will you, what you will tell to this patient? Patient is saying, you are saying that the stone is on the right side causing obstruction. Patient is saying, I have got a pain in the left side.
Yes, sir. Yes, sir.
Sir, okay.
Like to do the CT scan.
Yes.
Patient is not willing.
Like to do the CT scan.
So can you
Because the
give
pain
medical
is on
line
the
of
left
treatment?
side, so I will like.
Yasir, can you give medical line of treatment? Will you like to give medical line of treatment?
No, sir, I will not be able to give the
Nikhil,
medical
will you like to
indication.
give?
No, sir, not really, because it's a bilateral renal stone. It needs a metabolic workup also, this patient. And here there is the risk that this patient is, though it is large cells having no pain on the right side, could be this thing, long standing stone also with non-functional status.
Dr. Pankaj Maheshwari just told you that there are enough of proof to say that even a large stone can come out.
Yes, sir.
So then what is
9.8.
wrong in saying that? So, okay. So Nikhil, tell us what are the indications of doing surgery in ureteric calculus?
The ureteric calculus, obstructing calculus, large cells calculus that is present.
Number one, what is the first indication?
Solitary functioning kidney with obstructing ureteric calculus.
Okay. Second,
Second, large size calculus, the size is more than 10 mm or above 6 mm.
okay. Earlier it was more than 6 mm. Fine. Third,
The third one is it is a linear long calculus.
pardon?
If it is a linear calculus of long,
What do you mean by that?
sir, if it is a lengthy calculus, like long calculus that is present, chance of passage is less.
Okay. Okay. Well, what is the next?
Sir, if
Any features of infection,
One is infection, bleeding, severe pain, intolerable pain.
bleeding.
Patient has got continuous pain.
yes, and also
Then-
failed medical therapy.
Yeah.
Expected.
Then loss of renal function. Patient is getting hypertension.
Yes.
Correct.
and
Creatinine is increasing,
creatinine
Right.
increase.
and the stone is in the same position for more than 3 weeks.
Right.
Correct.
Yes, sir.
So, Pankaj bhai, you want to add something?
No, sir.
Okay. So I will tell you what we did in this case. Patient had a pain. So we again repeated sonography. So it was showing still the stone at the same position on the right hand side. So we tried to attempt. This is a shortcut. So we did cystoscopy and we tried to do URS, but we were not able to go beyond the lower 1/3 of the ureter. So what we did was to do a digestanting, and we told patient, okay, this is an X-ray. It is not showing stone because it is a radiolucent. And we did a digestanting. Fine. Okay, Yasir. Now what? Now this patient has come to you. I have done failed URS, done the digestanting, and the patient has come to you. So what you will like to do?
So digestant was done on the one side only.
Pardon?
Digestanting was done on the ureteric
Right side.
only, no, sir?
Only on right side.
Okay, sir. So in the next setting, I will like to remove the digestant, and if the stone has not passed spontaneously, then I would like to take this stone out.
Nikhil, what you like to do?
Sir, I would like to again take up this patient for ureteroscopy, sir, because the stent is there, it might have dilated well now. So there is chance that clearance of stone will be more, sir, on the right side.
You still don't want to do a CT scan?
CT scan I asked, sir, but patient is not willing, sir.
No,
But now, will you want to do it without a CT scan? Now you should say, I'm not willing.
exactly.
Now we already know the stone location, sir. So we can
But then why
guarantee.
were you unable to get in? What was the reason you were unable to get in?
So maybe there could be a kink, sir, there because of the
So we will
stone.
need to evaluate this by doing a CT scan. You see, whenever there is a patient who comes with a failure at some other center, don't operate the patient directly, reassess everything.
Plus, stones are not seen on X-ray. You have
You
one
do
more
not
point
know
is
to
a
what has
radial.
happened. Maybe there was a ureteric perforation, which that person has not written in the notes. Okay, so a reanalysis is absolutely essential. Even if this patient had a CT scan previously, I would still repeat a CT scan again. You see, let this case get over. I'll tell you a short story how I recently got stuck by not investigating a patient.
Yes. So what they are saying is most important. In the beginning only I told you that whatever I am showing you, these are the shortcuts. These are not, you are not supposed to answer like this in exam. And second thing, please think like a consultant. Now this patient has come to you, you must say, I will like to do, because you want to find out what I have done. Number one, I have done any Gochi inside this case or not. That is number one. And number two, what was the cause of my failure, and why patient has got stone on right side but the pain on the left side. Okay.
Yes, sir.
Fine. Okay, Achin, show them CT scan.
Yes. I don't
Show
have
them the last
link.
film. Yeah.
No.
Yes. So Nikhil,
Yes.
tell us now.
You see the importance?
Yes. Yes. There's a partial duplication.
No, it's not partial.
Right. I'm not able to see both.
Show the lower down.
It's a complete duplication, man.
Oh, yes.
What are the things you are seeing? It is a complete duplication.
Yes, it is complete duplication. Yes, sir. The left.
And by just show the report, Achin.
Yes, sir. Report shows duplex collecting system including entire length of both ureters on both sides, with both sides showing orthotopic opening in the urinary bladder at the respective UJ. 0.6 into 0.5 centimeter calculus in the proximal left ureter of the lower renal moiety, approximately 7 centimeter proximal to UJ, with proximal hydroureter and hydronephrosis, with mild inflammatory urothelial thickening. Two small 0.5 into 0.4 centimeter and 0.3 into 0.2 centimeter sized calculi seen in the distal right ureter of the renal moiety at the level of crossing of iliac vessels, approximately 4 centimeter listed to the PUJ, causing mild proximal hydroureter and hydronephrosis. Two small non-obstructing calculi measuring 2.5 mm seen in the lower calyces of right kidney.
So now you understand, Nikhil, what has happened?
Yes, sir.
When I went inside, I saw the ureter,
Sir.
which was the most proximal to my entry. Okay. Without
Yes, sir.
realizing that there are two ureters,
There are two.
I enter into that ureter, which is upper moiety, because lower
Upper
moiety will be lateral.
Yes, sir. Yes.
And patient has got a pain on the left side because there is a stone even in the left lower moiety ureter. Understood
sir.
the importance of CT scan?
Yes, sir.
And they have not mentioned, but here there is even a stent in the right upper moiety. You can see it. See, can you see this?
Yes, you can see the stone.
And
Sir, in continuation with this case, sir,
uh,
just that small story. When you had come to RG, I was the chief there. If you remember, sir, we had the same case. Somebody had done URS outside, could not remove the stone.
correct.
Then I did a CT and I called you that, sir, there is a stone in the upper moiety ureter which is non-functioning,
Right.
and that parenchyma was absolutely thinned out. Then we did that. Only we removed that ureter and that upper pole.
Upper, correct.
Yeah.
Maheshwari, you were
Yes,
also okay. Anyway, we finish off this case by
Yes.
doing bilateral URS, bilateral readjusting, and spent money from my pocket. Okay. So please understand the importance when you practice in private. We have got another 2 cases which will finish in 5 minutes. But before that, let us hear Pankaj's. Let him narrate.
Let's finish the cases, sir. I will.
Okay.
Yeah.
Fine. By next.
Yes, sir.
No, just show them the X-ray. See, this is the, I don't have, this is because this is very old case. I don't have any CT scan, but as you can see, the left fossa is absolutely empty. And this is a staghorn calculus, as you can see on the right hand side. Patient had a little
Right.
about, I think, I'm not sure, but 1.6 was the creatinine. And this is the case. Just tell me, how will you manage? Of course, all other thing, medical, this thing, biochemistry and everything, you are going to find out and do the parathyroid. All these things are okay. That we already discussed earlier also.
Yes.
Because Dr. Hiren is there and Dr. Maheshwari is there. They are really master in stones. So they will throw good light on that. So I want to know from both of you.
Sir, I would like to go for prone PCNL, sir.
Sir, I will.
Okay. Oh, Gite sir has joined. Good. So, Nikhil, I want to ask you, are you very confident that you will be able to remove all the stones by PCNL?
No, sir.
Number one, how many punctures you are thinking that you will be doing? What are the chances? Is a solitary kidney. So what are the chances of complication and losing this kidney? So how will you counsel this patient and what you will do now?
Sir,
So number one, how you are going to counsel this patient? And number two, you will be restricting yourself only to PCNL. That also limited number of punctures. Or you will be doing along with that something else.
yes. Sir, if given the armamentarium, sir, ECIRS would be best thing to do.
No, how you are going to counsel this patient? Please tell me.
Sir, counseling, I would tell this patient that there is a chance that there may be a possibility that we may not completely remove the stone, and the patient may need a second sitting, sir, for this patient.
So if you don't remove the stone in this case, what are the complications you will come across?
Sir,
I'm not talking of intra-op. I'm telling you, you have not removed the stones.
Yes.
So what are the complications you will come across? You have invaded the system.
Yes.
The stones are remaining behind. So what can happen? Yes, Yasir, answer.
When going to the non-functional kidney, renal insufficiency.
No, why non-functioning kidney?
If the stones are there.
Hello? Nikhil? Hello?
Yes, sir, we can hear you.
Yeah. Fine. So they both of them are not there?
Yes, sir, somehow they are not there.
Yes, Yasir. Unmute yourself.
Yes, sir.
Yes, Yasir. Just tell us.
So I was there, sir. I was saying that if the stones will remain there only, this can progress into the infection, sepsis.
Yes, infection, sepsis. Then after removal of the digestant, one stone may come down and can cause the obstruction to the ureter.
Yes, sir.
Right?
Yes, sir.
And again, if the stone is left behind, again it can form the staghorn calculus. So these are the very important things you are going to tell patient, that in case if you cannot remove, and why you cannot remove, because the solitary kidney you don't want to damage. Okay. So Nikhil, along with PCNL, what else you will do? Suppose the stones are not removed. You have done how many puncture maximum in your institute you have seen people doing?
Sir, 3 punctures for 3 different cases.
Pardon?
Three punctures.
Very good. So suppose in 3 punctures, after that you stop or they keep on doing more punctures?
No, sir. They stop.
In such stones, sir, we like to do the punctures initially only. 2
Okay.
to 3
So after 3
punctures.
puncture, if the stones are remaining, what else you will do?
So here we subject the patient to ESWL, depending on the size of the fragment that is remaining at once.
Okay. What else you can do?
So in the exam, you should talk about all the options. One, you can say that you will do staged PCNL. Second, you can say PCNL with RIRS when you're removing the stent. Third, you can say when during PCNL you can use a flexible nephroscope. That also you should talk about. And fourth, you could have planned it as a ECIRS right from the outset. So all the options, when sir is asking what else, you should tell all these things 1, 2, 3, 4.
He has given you the best answer. So in exams, you must talk about all these things.
And yes,
Okay.
ESWL also, what you said was also correct. ESWL can also be considered.
So you should say during that, what are your the reservations in this case, your limitation in this case, how you are going to counsel this patient during intraoperatively. What are the different methods you will use for the total clearance of the stone? Number one. And number two, if you have to abandon the procedure for any reason, either it is taking a longer time, or if there is a bleeding, okay, or if the patient's pulse rate is increasing, BP is decreasing for any reason, or patient is going into hypotension and you have to abandon the procedure, then post PCNL, what you will do, stage, RIRS, and all these things. Okay?
Yeah.
Fine. Anyway, because at that time also we didn't have any other, like we didn't have mini perk also, we didn't have nephroscope, flexible, RIRS, anything. So what we did was this, just show them, okay, and we removed the stone totally, and I will send you one paper where it has been shown that number of punctures, the chances of nephron damage is not much. Okay, this is per operatively we have taken. It is appearing on the right hand side because patient is in the prone position. Okay, total clearance we had done. Fine. The last case, just show them.
Sir, next time, whenever there is time, sir, I'll show a small video of ECIRS.
Okay.
I have described the procedure while performing it, so that we can show them next time.
Yeah, good, good. Okay, Yasir, this is the last case. What is this?
It's an X-ray KB showing an. Should I directly go to the diagnosis, sir?
Yes,
What's
it's
the
a
diagnosis?
spotter.
Directly tell me the diagnosis.
The radio opaque shadow on the both sides. The radio opaque showed they are just joining in the midline. So most likely it's in the staghorn calculus in horseshoe kidney.
Yeah, so it's a staghorn calculus in the horseshoe kidney. In each and every calyx, I will tell you the history. Patient's creatinine was 3.2. Earlier, he had already undergone PCNL on both the sides, and patient has again come with this recurrence. So Nikhil, now in this case, what do you like to do?
Sir, directly surgery, sir. Like what type of surgery?
Yeah, so what do you like to do? So where you take the puncture in horseshoe kidney? Will you like to do angiography?
Yes, sir, definitely angiography.
You want to do angiography?
Yes, sir. Before planning the procedure, I would like to get a CT.
But what do you think? Where will you will be able to manage a puncture where there is no artery? How many punctures will require?
Multiple punctures.
Then, do you think angiography is going to help you in any way?
We can avoid at least the major things from where the vascularity is coming.
Where the vascularity comes in horseshoe kidney, posteriorly or anteriorly?
It can be anomalous. From anything it can come, right from the aorta to bifurcation.
No, I agree, but it will be anteriorly or posteriorly.
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 Yes, sir.
Yasir, where the arterial supply will be?
Posteriorly, sir.
Means if you do it in a prone position, you will come across the vessels.
No, sir.
Huh?
Prone. No, sir. That is a place where we have to do the function.
So then, Yeah, you will get blood supply from maybe from external iliac, you may get it from aorta. Yes, agree. But all are anterior. Then, so anyway, you can talk in exam. Pankaj bhai. Pankaj has left.
Yes, sir.
Pankaj, do you think in this case one should talk about angiography?
I would not.
See, very simple.
Yes. Angiography will not really help you in this because the most common puncture that you take for horseshoe kidney is the upper calyx puncture. And that's a fairly a vascular area for horseshoe kidney.
Vessels are below and towards the isthmus.
Yes.
So Nikhil and Yasir, you knew the answer now?
Yes, sir.
Yeah, I don't have mild rotated kidney at present. Next time I may show you. Okay. In that, yes, people are saying that you must do angiography.
You should say advantages of puncture in horseshoe kidney. It is a low-lying kidney. Calyces are posterior and upper calyceal puncture is very easy. And vessels are below and not above.
So anyway, now you know the last earlier case, pancake kidney, and this case, horseshoe kidney. Now you know it?
Yes, sir.
Yes, yes.
Okay. So anyway, what are the different ways of tackling this stone?
Stage.
It is crossing all around. It is going even over the isthmus. I think there is no other alternative but to do only PCNL, multiple punctures, and remove this stone. But otherwise, if there is a single stone or 2-3 stones, which is the best puncture?
Upper folds.
Pardon?
Upper folds.
Upper fold. Okay, Pankaj bhai, you want to talk something about puncture in horseshoe kidney?
Yes. So the access, as they have said, is always preferably through the upper pole. This puncture is more medial and more vertical. So the tract is more medial and more vertical. You will be able to access most of the kidney through the upper calyx puncture, except the isthmic calyx. And in stones like these, say where it is completely filling the kidney, you should still keep open surgery as one of the options.
So I think this is the best answer, that you have to keep open option, to patient. This is the most important thing. Okay.
So in exam, don't get swayed by that you have to talk of newer things. You should talk about conventional open operation also wherever it is indicated.
Yes.
So anyway, so we did just show the next slide.
Yes, sir.
Anyway, we were bold enough. So we, in a 3 different sittings, 14 punctures, then we removed all the stones because he was already operated earlier. So, and it was a horseshoe kidney. So I said, let us take a chance. As long as he is not bleeding, he is not developing any complication every time. I became more and more bold, and with 3 different days, we did the number of punctures and we removed all the stones. Okay, at least he had followed up for 1 year. Till that time, he didn't have any recurrence. Now I don't know. So few of the cases, I'll show you the full the stones which we removed. Fine, but you must talk about open. So in earlier case, as Dr. Hiren Sodha said, you must talk of all different modalities, and here you must talk of open as an alternative. Fine. Okay, Pankaj bhai, your history, your story.
Yes, yes, yes. So recently, you see one patient who has been on dual antiplatelet agents was a history of aortic valve replacement sometime back. Got admitted with one urologist for colic. On day 1, they did a CT scan, showed a 3 millimeter UV junction stone. So obviously the treatment was conservative. Patient was conserved for 4 to 5 days, but he continued to have severe pain, intermittent fever. Now, in view of his valve replacement and dual antiplatelet agents, he was sent to my hospital because we have a good cardiac backup. The mistake I did was, there was a CT scan. I did not reassess the patient. I took him for stenting. Post stenting, the pain continued. And this is when I realized that then we reassessed and we realized that there was a large subcapsular collection. So why I should have thought that because he had just a 3 millimeter stone, why was he getting such a severe pain? We don't expect such a severe pain with a 3 millimeter lower aortic stone. So I should have reassessed the patient. But because he had a CT scan just 4 days old, I skipped that CT scan. I should have at least done a sonography. I put in a stent without doing any investigation. And now when you find a hematoma, because he was on dual antiplatelet agent, whatever fornical tear he had led to a large subcapsular and perineal hematoma. Now this hematoma gets blamed on the stent. Though there is no way a stent can cause such a big hematoma, but because we have not documented it pre-op, it gets blamed on you. And later on becomes very difficult for us to explain to the patient that this should have been, this could have been there pre-degestenting. So any patient who comes to you where symptoms are unexplained, where some surgery has failed, where you cannot explain the prior course of the patient, reassess the patient. So nobody can blame you for doing one extra CT scan, but skipping one CT scan can land you a lot of problems. Not exactly CT scan, some radiological investigation.
So Nikhil, Yasir and all of you, I hope that you have now seen why we are presenting all these cases, so that you should know. If I show you everything which is as per protocol and done perfectly like given in the book, then you will not learn from the mistakes. And I don't want, or any one of us, we don't want you to make mistake either in exam or in your practice. So Dr. Pankaj Maheshwari has told you such a beautiful story. Is very important. Okay?
Yes, sir.
Fine. Dr. Gite has joined. He wants to comment anything. Okay. Hiren, you want to add anything?
No, sir. Excellent. Good collection of cases and good discussion.
Yeah. Only I had one case of malrotated kidney, but somehow I
Yes,
could
sir.
not find it. So anyway, we'll see next time. Okay.
But Gaurang bhai, really the effort you are taking for this training is really remarkable, and you really deserve 3 cheers.
All of see Pankaj bhai, because of you people, I'm
select karna वगैरह, it's an effort, it's a big effort.
yeah,
Really,
we are
sir.
doing
Really.
trying our level best, so that now we have to end, as you said now very rightly. If you have got 5 minutes now, I have asked Achin to just talk about the anomalies. So can you just talk on anomalies, Achin? You are
Yes,
prepared?
I've prepared, but it will take 15-20 minutes minimum.
Oh, no, then I think it's
Next
too
time,
much.
Rakhi.
Then next time we'll keep it.
Okay.
Yeah. Okay then. Thank you very much.
Good night,
So
sir.
just one,
Good night, Gite sir, Maheshwari
Thank
sir.
you, sir. Good night.
Good night, all
sir, one,
students.
Right. I
sir,
think
one
Nikhil
doubt I
wants
have.
to say something.
Yeah, doubt. Tell us doubt.
Sir, one, because in exams in our rounds also this is frequently asked, sir, so I just wanted to clear this thing.
Yeah.
So if it is a solitary functioning kidney and with a stone of significant size, sir, like around 2 centimeters or 2.5, like partial staghorn type of stone is there, what would be the best modality of intervention to preserve the renal function, sir? Like we are asked like whether you will go for an open surgery or a PCNL or an RRS or
Okay.
like
Nikhil, I'll tell you. There are two things. One is I can quote you the many papers where it has been shown that PCNL, the damage to the nephrons are not much and hardly anything. Not only that, we have done 2 series. My 2 theses. One was by Tanvi. She has done DTPA renal scan. We have done more than 70 cases. Number of puncture, size of the puncture, nothing matters. and there is hardly any loss. Okay, even 3 punctures, 4 punctures, 24, 28 dilatation also. Number 1. Number 2, after that, we have done one more study of CT IVP, that is pre-op and post-op. So any time between 3 weeks to 3 months. And that also 70 cases, of course, it's not a very big number. In that also we have found out there is hardly any no anatomical changes we are seeing. So functional as well as anatomical. And there are, I have got a papers also, many in the literature also, which has shown that it hardly matters. So if you have done properly your PCNL as per the guidelines, whatever you are being taught, okay, I don't think, and the best will be PCNL, because PCNL will do the total clearance, and you will have the good preservation of the kidney tissue.
So how to defend this argument, sir? Like,
Specifically
you
to
are
answer
doing
your
it.
question, I will tell you, because it is solitary kidney you asked. So PCNL is safe in solitary kidney. It's been well documented in literature, as long as you are not butchering and you're doing PCNL. Secondly, compared to nephron loss, what sir said, PCNL may be having some few hundreds versus thousands of nephrons are lost in open surgery. So that is also, literature is very clear that compared to open surgery, definitely PCNL is better, even if you're doing 2 or 3 punctures.
So here the argument is like in open surgery, we are not even entering into the kidney parenchyma, we are opening the pelvis. So the nephron loss is least like that.
We are talking about staghorn stones. So whether you're doing anatrophic pyelolithotomy or something like that with just a pelvic stone, okay, pyelolithotomy would be fine, but with a staghorn, you will not be able to clear it.
Like the pelvic stones.
But Nikhil, are you sure during the open surgery you will not come across the vessels, or suppose you come across a bleeding, if there is an abnormal vessel, you
See,
may
if it is a pelvic stone and it is a small stone, you would rather do RIRS. Why would you do open surgery or PCNL? So the debate is only for those larger stones.
Pankaj bhai, aapka view on that?
Yes, sir. So I have put 2 articles in the chat today. One is about renal function after staghorn PCNL, and one was a small article I had put about post-obstructive diuresis. So I thought these were quite interesting articles, worth reading them. Now, recently there is a study presented, I think in this time's EAU, where they have compared renal function post-RIRS and post-mini PCNL. And they have found that the renal function post-RIRS and mini PCNL, there is nothing to choose. So the renal functional loss depends more on the stone factors rather than the treatment factors. So associated diabetes, associated infection, residual stones, these would be more important causes of renal functional loss rather than the procedure per se. Obviously, doing a wrong puncture or traumatizing some vessel would lead to a significant functional loss, but with a well-done PCNL, the functional nephron loss is less than 500 nephrons per tract. And this was a study where the tract was made to the tune of around 30 to 35 French. With tracts which are much smaller these days, the renal nephron loss would be much less. So if the more important thing is to make complete stone-free status, not to leave behind any stone residues which could be a source for regrowth or infection. And if you can clear complete stone, the functional loss with either RIRS or PCNL is nearly comparable.
So Nikhil, your answer. Now, if you go on a round with your boss, you can answer him?
Yes, sir.
Okay. Good, good. Any other question? Otherwise, then we'll leave.
Thanks.
Okay, Rajesh has asked, should we preserve any kidney which is grade 4 hydroeratonephrosis because of stones by doing stone clearance? I think any functioning kidney, it depends. Any functioning kidney, I will like to say. And what is the meaning of functioning kidney? There are 2 aspects. One is the relative function and second is the GFR. Pankaj bhai, you will agree with me?
Yes, 100%, sir.
So I think
this decision will be based on the, as you rightly said, on the relative function. What the opposite kidney is, what is the age of the patient. So in a younger patient, I would want to be more nephron preserving because the recovery potential at a younger age is much higher.
Yeah.
But in an elderly patient who is diabetic with a chronic stone, probably with opposite kidney normal, you may be more aggressive as far as the nephrectomy is concerned. In stone disease, as far as possible, unless it's a severely infected kidney or zero function documented by a nephrostomy tube, try to preserve the kidney.
Correct. So again, it depends upon, I think, case per case. How is the opposite kidney? What is the age of the patient? What is the function of that GFR of that kidney? Whether there is an infection, how big the stone is, what is the size of the kidney? So many, things are there, and we cannot just generalize.
Even if patient goes into renal failure, it helps in water diuresis.
Yeah.
And like sir said, it should not be a chronic pyelonephritic kidney. We are not talking about that.
Right. Okay.
Good night, sir. Good night.
Good
Gite,
night.
sir.
Good night to all of you. Thank you for attending.
Right.
Thank you, sir. Thank you, sir.
Yeah.
And all
When
students.
more people attend, we feel, grateful, and we want to really collect better and better cases and do the good discussion. So tell your friends and colleagues also to attend these clinics. It will be very helpful. Okay. And I want more people to come out and answer. You should practice how to answer, because it will help you not only in exam, also when you are presenting your papers in conferences, it will boost your morale. Correct, Pankaj bhai?
Absolutely, sir. And just I would inform one more thing, that tomorrow onwards, from 2nd to 5th, there is a semi-live conference which is available online and which is free for everyone. If you want the link for registration, I can put that link in the
please
group.
You put it on a group. We'll put it on all the groups. No?
Yes. Yeah. So it is from Germany time, so it will start somewhere afternoon 2:30, go until 10:30 at night. Excellent program, and it is 2nd to 5th, worth attending.
Very good. Okay. Thank you, Pankaj.
Okay, sir. Good night,
Thank
sir.
you.
Good night.
Thank you.
Good night.
And in future also, Pankaj, you don't have to ask. I think you should put, because this is a very important information for all of us.
True, sir. True.
Yeah.
Like, sir, even this Sunday, the circumcision program that happened was beautiful.
Yeah, morning, na? It was
Yes.
good.
So a very small topic was really discussed threadbare, and probably an extremely important topic for not only urology postgraduates, but even general surgery postgraduates.
Correct. I agree. Fine. So we should put all these programs.
Surely, I'll do that.
I'll
do that. Yeah.
Okay. Thank you. Thank you, all of you.
Thank you.
Thank you, sir.